The Senior Rehab Podcast is sponsored by Great Seminars and Books. If you need high-quality geriatric con ed that's worth your time and money, check out Great. Owned by the living legend Carol Lewis, Great offers courses and products created by recognized leaders in geriatrics. Learn the most effective techniques for diagnosing and treating your patients. Just go to seniorrehabproject.com/great and get $25 off by using the code SRP25. The show is also sponsored by you, the listener. Go to seniorrehabproject.com/join to find out how you can help steer the direction of this movement and join our monthly meetup. Once again, that is seniorrehabproject.com/join. Hit me!
Welcome to the Senior Rehab Podcast.
The podcast for rehab clinicians that want to better serve older adults. Shorts. This is Senior Rehab Shorts, the evidence-based segment for geriatric rehab clinicians, bringing you relevant and applicable content to better serve your patients, regardless of your setting. And now your host, Joe Daniels.
What is up, Senior Rehab Podcast? Welcome to another episode of Shorts. I feel like it's been a while since I've talked to you guys. Since graduated from my DPT program down at Nova Southeastern University in Fort Lauderdale. So go Sharks. Really proud to officially be a part of the DPT family. Set to take boards here in July 18th and start residency up here in Jacksonville, Florida with the Brooks Institute of Higher Learning on July 5th. So a couple weeks before boards, so that'll be fun. Looking forward to bringing you guys another good episode today. We're going to talk about the role of muscle strengthening in exercise therapy for knee osteoarthritis, a systematic review and meta-regression analysis of randomized control trials. And this is out of the Seminars in Arthritis and Rheumatism journal, published on March 18th by Bartholdy et al. And thanks to Jamie Lowy for the heads up with this one. So the objective of this study was essentially to analyze if exercise interventions for patients with knee OA following the ACSM guidelines definition of muscle strength, which I will mention later, strength training differs from other types of exercise, and then to analyze associations between changes in muscle strength, pain, and disability. All right, so a little background information here. Contemporary clinical guidelines for the management of knee OA obviously emphasize non-pharmacological approaches, i.e. weight reduction in those obese individuals, education, and exercise therapy, with highlights added to the value of exercise therapy. And so besides the beneficial effects on symptoms, strength training is advocated as an important component of of exercise interventions, as decreased muscle strength is common in this patient group. So the underlying mechanism by which exercise is beneficial for knee OA symptoms currently remains unclear. Theories have been put forward, including local biomechanical and systematic effects, yet with limited empirical evidence in support. And so in exercise programs that include or focus on muscle, the increase in muscle strength must be considered a necessary effect. And if a biological link between muscle strength and clinical benefits exists. However, it is unknown if the positive effects of exercise programs are caused by the increase of muscle strength, i.e. the biomarker, or other aspects. So therefore, it stands to reason to investigate if exercise interventions that aim directly at the biomarker, in this case muscle strength, yield superior clinical effects, i.e. decreases in pain and disability, compared to interventions with less emphasis on the biomarker, being muscle strength. So the objectives of the study were, 1, to investigate whether strength training interventions, as defined by ACSM, differed from exercise interventions not designed by ACSM on self-reported outcomes in pain and disability, as well as in muscle strength gain in patients with knee OA. 2, to investigate whether there's an association between muscle strength gain and changes in clinical outcomes in pain and disability. And 3, to identify a potential critical threshold for the minimum gain in muscle strength needed to likely change self-reported pain and disability to be expected. So Whole goal of this paper, guys, is to basically decide, one, are ACSM strength training guidelines better for increasing knee extensor strength and improving outcomes in those with knee OA compared to non-ACSM guidelines? And then two, if they are, what percentage of knee extensor strength increase do we need to make a difference on those outcomes in pain and disability? Okay, and so in terms of eligibility criteria for this study, they had to be randomized or quasi-randomized controlled trials comparing at least one exercise intervention with no intervention, a waiting list, sham, or a placebo. The trial population should be diagnosed with knee OA in either one or both knees. All studies having performed an exercise intervention and reporting a strength measurement of the lower limb and included outcomes on self-reported pain or disability were eligible. There were no restrictions regarding age, BMI, or gender. And we'll talk about a little bit about the age demographic later. Most of them were over 65, I think with the average age around 62. So exercise interventions were categorized as ACSM interventions if they described the delivered intervention according to the ACSM recommendation of strength training for this patient group. And so here's the ACSM definition of strength training for you guys. So it's a voluntary contraction against an external resistance typically performed in a specially designed equipment or with free weights. The external load should be above 40% of 1 rep max, corresponding to very light or light intensity, and the exercise is performed in 2 to 4 sets of 8 to 12 repetitions, preferably to contraction failure or muscular exhaustion. The exercise program should consist of at least 2 to 3 sessions per week. So again, for you guys, minimum 40% of 1 rep max, 2 to 4 sets, 8 to 12 reps, 2 to 3 sessions a week, okay? All right, so in terms of study characteristics here, 56 comparisons involved 4,699 participants. So 4,700 participants roughly, guys, nice big sample size. It is a systematic review there, so there's some good value and merit to this study, to either an exercise or a control. The participants on average were 64 years of age, there you go, with the proportion of women ranging from 36 to 100% between the two comparisons. 2 of the comparisons did not describe gender distribution, with the average BMI available in 46 out of the 56 comparisons, and a mean BMI of 29.6 and a range from 22.4 to 33.9. So 22 interventions followed the ACSM guidelines for strength training, while 34 interventions did not. The 22 interventions that followed the ACSM guidelines had a mean exercise period of 8 weeks with an average of 3 sessions per week, and the average number of sets of 3 for each exercise, 10 repetitions, and a load minimum of 40%. Of the 34 interventions that did not follow the ACSM guidelines, exercise period was also 8 weeks, 3 sessions a week, and then 33 comparisons had no intervention as their control group, 20 compared to a sham intervention, placebo, or attention control group, and then 3 compared with a waiting list control. All right, so 3 major comparisons here, guys. Muscle strengthening versus other types of exercise. Benefits of exercise were recognized with respect to knee extensor strength, pain, and disability across all studies, so everything improved. A statistically significant difference in favor of the ACSM guideline interventions with respect to knee extensor strength gain was found. So ACSM superior to non-ACSM in terms of knee extensor strengthening. However, no statistically significant differences between ACSM versus non-ACSM were found with regards to pain and disability. All right, so there's your first comparison. Now, second comparison, association between knee extensor strength and pain. So of the 56 comparisons, was not possible to calculate percent change in only 3 of those, so 53 did have good comparisons here. And a statistically significant association between knee extensor strength change and pain was found. However, here's the caveat, guys, however, it can be seen that an increase in knee extensor strength of minimum of 30% is necessary for a likely beneficial effect on pain. So in order to decrease pain levels in these folks with knee OA, you need to increase knee extensor strength by a minimum of 30%. Last comparison here, guys, association between knee extensor strength gain and disability. So of the 56 comparisons, only extractable data on disability were available in 47, so 47 out of 56, not bad. An association between knee extensor strength change and disability was found across all studies. So again, strengthening is improving disability. However, here's the caveat. It can be seen that an increase in knee extensor strength, minimum 40%, is necessary for a likely beneficial effect on disability is to be expected. So in order to change pain levels, guys, we need to be increasing knee extensor strength by a minimum of 30%. In order to change disability levels, we need to increase knee extensor strength by a minimum of 40%. All right, so those are the numbers, guys. A lot of good data here with a large sample size. And so reduced muscle strength, especially quadricep strength, is common among patients with knee OA, and therefore strength training seems to be well indicated. Achieving an increase of 30 to 40% in knee extensor strength is considerable, but not impossible with this patient group, according to the study. However, factoring age and general condition of this patient group in both pain and disability, together with the beneficial clinical effects from other types of exercise, and striving for an increase of 30 to 40% in knee extensor strength to add a small additional effect in pain and disability can seem inappropriate to clinical practice. More caveats here in terms of limitations of the study. An important limitation, according to the authors, is that the interpretation of the ACSM recommendation, and so they chose to allow a 40% resistance for improvement of strength, because this was the recommended for elderly, frail, or beginners as starting resistance. Furthermore, the non-ACSM interventions include a wide variety of exercise types, which are not all obvious strengthening exercise programs. So a further subgrouping of these non-ACSM interventions could have been valuable to identify specific differences with strengthening exercise programs. And then lastly here, further studies could evaluate the relationship between patients with knee OA performing exercise but not improving over the 30 to 40% compared to those who did improve over 30 to 40% to see what the major differences would be in both pain and disability. All right, so in conclusion, guys, here, results, 45 trials total, 4,699 participants, 56 comparisons, 22 of those were ACSM interventions, with the rest being non-ACSM interventions. Statistically significant differences found with regards to ACSM versus non-ACSM strength training guidelines in extensor strength. No significant differences observed with regards to effects on pain and disability. The meta-regressions indicated that increases in knee extensor strength of 30 to 40% would be necessary. So 30% increases for pain and 40% increase for disability in order to have those major differences. And then in conclusion, exercise interventions following the ACSM criteria for strength training provide superior outcomes in knee extensor strength, but not in pain and disability. An increase in 30% or of less than 30% in knee extensor strength is not likely to be clinically beneficial in terms of changes in pain or disability. All right, so there's your cutoff score, guys. I'll leave that up to you. Any questions, as always, feel free to reach out on Twitter. I actually changed my my handle to jdaniels_DPT instead of SPT. Also, find me on Facebook. Most of you guys have my number. Feel free to reach out. Until next time, guys, stay funky, my friends.
Hit me. Thank you for listening to the Senior Rehab Podcast. I appreciate your time, and if you enjoyed this episode, do me one favor. Share it with one other person that would benefit. Thank you. If you want to see the show notes or find more episodes, just go to seniorrehabproject.com. And until next time, my friends, do not forget to stay funky. The Senior Rehab Podcast is sponsored by Great Seminars and Books. If you need high-quality geriatric con ed that's worth your time and money, check out GREAT. Owned by the living legend Carol Lewis, GREAT offers courses and products created by recognized leaders in geriatrics. Learn the most effective techniques for diagnosing and treating your patients. Just go to seniorrehabproject.com/great and get $25 off by using the code SRP25. This show is also sponsored by you, the listener. Go to seniorrehabproject.com/join to find out how you can help steer the direction of this movement and join our monthly meetup. Once again, that is seniorrehabproject.com/join.